I know you're not.
Tell me I'm wrong.
Okay, well, hello everybody. Hey, by the way, Dominic, I love your TikToks.
Oh, yeah, thank you.
First time on our pod.
Oh, is that right?
Yeah.
Oh, wow. Look at how many people do we have back there? Wow,
Hey
it's
guys.
hello, everybody.
Hi guys.
Hey, John. Thanks all for
Hello.
Oh, it says video unavailable. Why is that? Let's see.
Oh, you're uninspiredspine.edu.
Okay.
Thanks for joining us today.
Okay, well,
You bet.
so we are actually here to learn and listen to you, to your expertise in Hutchinson in Kansas about your system. How is your daily work setting up a surgery, especially a surgery that obviously is very new to you? Now, certainly I am doing 6 surgeries in Crookston and in some other places, but it took me years to get there. So I was truly amazed that in such a short period of time, last time I was there, so efficiently we did 6 cases, and we did 6 cases in one room. So I think
By
that
what
is-
time?
I think we were around Bernice, what time were we done when we did those 6 cases? Oh, I think we don't hear you. Maybe they are.
Well, they might not have a microphone.
Oh, they might not have a microphone. Then they cannot talk. No, we don't hear you. We still don't hear you. They can actually call in with a phone, right?
Yeah.
They can. No.
If you guys check the link, there's probably a phone number you could call in. And then if you guys want to pass around your phone too.
Yeah. You can call in and participate the voice over a phone. Now, for people who don't know, this is going to be one of our podcasts. Our podcasts are practical things that we teach people about how do things and how do things better. So why don't we start in our podcast format?
Well, I think it'd be nice if we can wait until they have the microphone so that they
Yeah.
can introduce themselves too.
Yeah, absolutely. But we can as well use the time to introduce
Mhm.
ourselves and as well, give a little background about what it is while they are figuring that out.
Sure.
Okay.
Ready?
Mhm.
Hi guys, thank you for joining. This is Essence of Medicine. Today we're going to be talking about OR efficiency. The reason we chose this podcast today is because we've been doing surgeries in Kansas for only a few weeks now, which is 1 day a week. And already in just a short amount of time.
1 day a month.
1 day a month, but for a few months.
Yeah.
And in this short amount of time, they were able to really be efficient and learn how to maximize that OR time. So we were able to do 6 cases in just a matter of 1 day.
1 day, yeah. Now, I'm Dr. Bassi for Essence, and you see our team member in Minneapolis. Please introduce yourself.
Hi guys, my name is Alyssa Hopper. I'm a PA with Inspired Spine.
Hey, I'm Dominic Moore. I'm also a PA, just starting.
Excellent. Now, while there are other, if anybody want to introduce yourself, please do so. I think our team.
Hi, I'm Kim. I'm the nurse manager of the operating room.
Okay.
And I'm Taylor. I am the charge nurse and also the circulator of the operating room there.
Excellent. Now, I'm not sure if you have the sound in our Kansas partner or not, but they can call in definitely with the same link and the same number. But why is efficiency important in the OR? I mean, I'm going to ask the newest member, Dominic. Dominic, why is efficiency important? Why is it important to be doing something faster or more efficient in the OR? Not necessarily faster, but more efficient, because the goal is not to be fast. The goal is to be efficient. But why do you think it's important?
Yeah, well, the OR is typically one of the highest revenue areas of a hospital, and also it's got to be a really good, smart use of resources because patients go in for very important things. It's not just like a mechanic shop. You're not just rolling somebody back to the body shop. So you need to make sure that when something's happening back there, it's what you want to be happening, and it's happening how you want it to be happening. And that's what efficiency is about.
And very well said. But more importantly, does anybody know how much a minute, and it's calculated not by hour, by minute, OR cost, running OR cost? How much does it cost? So I think our partner in the Hutchinson, they have now voice. They're still trying to manage the thing there. I'm going to.
So you guys in Kansas, if you don't mind muting your TV, that way when you guys use your phone,
Yeah,
there
or
won't
computer. No, you don't mute keep the sound, but I think you should mute your microphone, I believe. Otherwise, it's going to echo. We can try a few things and see how it goes. Okay, you can, on your phone, you can unmute and first of all, introduce yourself and.
Well, how expensive is an OR per minute?
I want to.
Can you hear us now?
Yeah.
Yes, hello there. Hello, everybody.
Okay.
What a great team. So maybe somebody want to introduce all of you, who you are, how much you have been in practice, and your expertise.
So my name is Bernice. I'm the OR supervisor here at Summit Surgical. I have pretty much every type of employee that we have in the OR. We have some sterile processing nurses. We have our OR aides here joining us today. Prep techs. We also have Melissa and John who help with prepping the patients before we get into the OR with making sure that we have everything in charts and everyone's on the same page about our surgery schedule here.
Fantastic. Now, the question was, we want to just throw some numbers around. How much does it cost? As a matter of fact, it was just recently I introduced you to Dr. Sivanikessan about this OR efficiency and economic. The cost of the OR is calculated in minutes. Now, do you want to just throw a number out? Anybody welcome? Throw a number out. I want to just gather numbers. How much a minute in the OR cost?
$26.
Okay, we have $26. Okay, who else?
100.
300, 400.
100, 400. 400 means 1.5 hour surgery in the OR. Dominic, can you calculate? What a 1 hour?
lot.
Okay, now let's just calculate take your cell phone.
Mhm.
And people throw numbers out there, calculate 1 hour, how much it would cost. So,
All right, the highest I've heard was what, 400?
First of all, 26.
I said
26, 26.
26 times 60.
So 1.5 hour surgery times 26, 2,340.
Okay, so 25 times 60 makes how much?
25 times 60, all right.
Oh, you said 25, right?
She said 26.
It's 26. Okay, sorry. 26 times 60.
Oh, just 1 hour surgery, I meant that.
1 hour surgery, correct.
1,560. So about $1,500 an hour, which I know is probably way less than what we probably.
Yeah,
Yeah.
I'm thinking I need to readjust.
Maybe
my number.
not very accurate.
Now, we had a number 400. Punch that number in.
400.
The real number is between 26 and 400. The real number is somewhere between.
Okay,
Yeah.
I feel 150.
Okay, so the 400. How
We've
much?
got 24,000 an hour.
So $24,000 an hour. So you guys want to throw some other numbers out there?
Well, 200 would be half of that.
Yeah, I like 150. So 150, 200.
Well, you do the math.
well,
Okay,
so
let's do
how much
200.
would that be 150 per minute for a 1 hour surgery?
Oh,
Well, 200 would be
200.
12,000. So that's my safety
Okay,
blanket.
now,
and then
Now
150 is
imagine,
9,000. So.
okay, so OR, you understand there are lots of skilled people. They all have to be getting paid.
Mhm.
And as well running OR. Just if the OR is like a Department of Defense, they buy a washer 5 times, 10 times more expensive. Medicine is the same. Anything in the OR, anything related to OR is just more expensive. As well, people who are paid there are more expensive. Now, let's we have 200. Does anybody want to throw another number out there?
I'm still with 100.
100. Okay, now I can give you the data for 2016. I don't know current data, but we can find out. As a matter of fact, Dominic, I want you to work on that and find out what are the current number. In 2016, when we published our paper, in a rural hospital, it was $64. In a bigger city hospital was $95 per hour. In a high level like Mayo, it was $115. But that is 2016 number. Now, let's say, and you guys know the numbers are not the same as in 2016, right?
Right.
You don't buy anything you buy now. You don't pay 2016 prices.
Not even close.
Not even
Not
close.
even close.
So you can imagine all of that has kept up with inflation. But now let's say you are in a fantastic paradise and it's 2016 and before COVID, before all the inflation and so on, and we are paying let's say $90 per hour for a surgery. So that 90 times 60, that makes how much per hour? Oh, we don't hear you. You're muted.
You're muted, Alyssa. Wait, can you guys hear us?
So
We
90,
got
Oh,
okay.
5,400.
Now imagine the surgery is now, and that is independent of if you are doing surgery or not. Okay, if you have people in the surgery in the room, if you have hired people, they punch in until they punch out. These people who are in that environment, that's the cost of the ward. Now I want to go and just calculate for me is a surgery that is 5 hours versus a surgery that is 1 hour. What's the difference?
at what cost?
Say $90. We said
$90.
$5,400 per hour, and we have now 5-hour surgery or 1-hour surgery. What is the 5 hours? We know what a 1-hour surgery is, $5,400 versus a 5-hour surgery.
The difference is $21,000, just over $21,000.
And in reality, in 2023 is if you go bankrupt or if you can operate a surgical center or hospital. And so surgery center, the cost is lower. Hospitals are higher. And we use the high number for 2016, but that high number, I can guarantee you, is the average number for now. Now, Bernice, how long have you been administering that surgical hospital in Hutchinson?
1 year.
1 year. Now, in average, how many patients, when you have a patient in the room, how many staff, not including the surgeon, but how many staff do you need to run one room? Now, that is not necessarily anybody who's in the room, but as well, and Bernice, tell us, to do a surgery, who are the staff that you have in the room? Who are the staff are supporting outside of the room?
So in the room, about 4 or 5, depending on the case. And then we obviously have our auxiliary staff, our instrument processing, and our OR aide. So a couple more, about 6 staff members will be involved for one surgery.
Yeah, and as well, that doesn't even include the PACU or other staff that are needed before and after to check.
Right. That is just in the OR.
Yeah, that is just in the OR. So, now, you can calculate on top of your head, that what a huge difference it makes to get efficient in the OR. Now, it gets as well a little more complex because the insurances they actually don't pay you for the minutes spent in the OR, because that would be easy, you just minute in, minute out, they pay you a thing. Bernice, tell us, how is a health facility, or maybe somebody else can as well chip in, how is the health facilities paid for surgery performed?
How did we get paid for surgery?
Yeah.
We have an OR rate based off of time frame that we bill to insurance, but insurance, of course, has their contractual write-off and what they will pay.
Yeah,
So
but it's
the
a fixed
amount
amount,
of-
right? It's a fixed amount.
Yeah.
There are some variables there, like if you have a high BMI complex patient, you can add some codes. There are so-called CPT codes. Those CPT codes, obviously you negotiate with the insurance company, but there's a fixed amount that you get paid. Now,
Yeah.
insurance, they should, but at this point, they don't really care if you need 5 hours to do that surgery or 2 hours you need to do that surgery. And as a matter of fact, it is get even a little more complex because it's different from insurance to insurance, but more or less it is a fixed amount that the facility get paid for that surgery. Now, I hope that slowly we are all realizing what a huge difference it makes if you can do 5 surgery or 1 surgery in 1 room in 1 day. Does that slowly sink in what the cost of the operations are, how many highly skilled people are involved versus how you are getting paid in the economic of the healthcare? Does it make sense now how important it is, the efficiency in the OR? So yes, Dominic, please go ahead. Yeah, let's have a conversation, okay? I want everybody contribute and have a conversation about this. Please go ahead, Dominic.
So I looked into some numbers, and in 2020, Texas Tech published a little review of different literature and whatnot, and the highest end they get, not including anesthesia costs, so this is without anesthesia even, is 131 per hour in their OR.
Well, and there is a reason they get the anesthesia out of it, and as well, surgeon is not included in that.
Mm-hmm.
So, and if you add that, you easily can double that number. Okay, but yes, 130 is the average, which makes sense. If it was 2016 was 65 to 94, it makes that average. So what that means as well that my hat up to rural medicine, because in rural medicine we can always provide a good care cheaper. We know that. Okay, so now having said that, we have to separate 2 things here. It is not about being fast, because you can try to be fast and then you make mistakes and then you have bad results. Then it's irrelevant what you do. It's about providing the same care or better care more efficiently. It's about efficiency, not about fastness. Now, having said that, these 2 are not irrelevant. These are not unrelated. There is a study that I go and show people, and the references, we will add the references to this podcast, that shows every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. That means if you can make a surgery that is in 1 hour and somebody else perform the same surgery in 2 hours, it's like a compound interest. You have with 1 block of half an hour, another block of half an hour. So you're adding twice compound 17% to the complication outcome of the surgery. This was based on 388,000 patients, and they bunched all the patients in one meta-analysis. It was a meta-analysis of the different the surgeries. Now, the surgery that patient is prone, meaning laying on the belly, those have actually even higher rate. Now, I want to ask maybe somebody on the Hutchinson team, why do you guys think that the surgeries that are prone, meaning patients on the belly, every half an hour adds more risk versus patient is on the back? Do you, any idea, any guess?
Anybody? There is more risk for injury being on your belly.
Yeah, pulmonary injury, because You have to, when you are on your, exactly, when you are on your chest, you have to put higher pressure to ventilate them. And higher pressure, our natural breathing is a negative pressure. The way you and I are breathing right now, we expand our lung, we suck the air in, right? But does that make sense? In the anesthesia, you don't do negative ventilation, you do positive ventilation. You push the air in. And believe it or not, if pushing the air in was the better way for breathing, nature would have figured it out how to do that. So it is an unnatural way of breathing. So this is what I just told you, is just all the risk associated with the anesthesia itself. Time under anesthesia is an independent factor of perioperative outcome. That is the consensus of that study. What that means, not rushing it, but if you do the surgery half an hour less, you're saving the patient 17% combined risk of the surgery. Now, that is why we can do a 3-level fusion in our surgery center and nobody else can. Because we made a 3-level fusion, a 1.5-hour surgery. Now, I know that you guys in Hutchinson, it is a hospital, but what is Bernice, I want to know your expertise. What is the longest surgery you guys are comfortable doing in your place? Or what is the longest surgeries you have done? What is the average? Give us a little about the time, anesthesia time associated with the surgeries that you guys perform.
So we mostly do orthopedic and GYN surgeries, and those can take about 1.5 to 2 hours for a patient to be under anesthesia. Our GYN cases, if we do an open procedure, those can take 3 hours to 4 hours, depending on the patient, depending on some of the other factors that involve the surgery. So I would say for our longest cases, it's about 4 hours. And you can definitely tell the difference by the time you get to PACU, how the patient is feeling, how the patient is going to be doing after.
And they've had more meds just because the anesthesia's had to keep them under longer, and that affects your body too, and waking up.
Absolutely.
What do those differences look like to you guys?
Good question. What are the specific questions? Somebody who has a 4-hour surgery versus somebody who had a 1-hour surgery.
They recover faster, they wake up faster if they haven't been under anesthesia as long. They take less meds, and
some of the older population, definitely that affects their cognition. They're going to have more problems with atelectasis later. Like you mentioned, we're having to breathe for them. So some of those alveoli are going to sleep, and then we're going to have to wake them up for that. So
you masterfully summarized that. There is actually a testimonial from a nurse anesthetist in Texas when I went and did that surgery. First time there, and you guys know which one I'm talking about, that she describes as well the anesthesia related, how much easier it is to bring them back, because let's put it in a term that everybody understands, everybody who is not even in medical staff. Imagine you have to fix your car while it's running on the highway. You slow it down, but car is still running. That is how we do surgery. This patient is still, the heart is beating, the system is beating, the brain, we put it at the minimum level, and we have to fix it. We have to pump them with so much medication. It's a complex situation. We control their heart rate, we control their blood pressure, we control the breathing, we control what it goes in and out of it. It's a very well considered balance of medication that we put in them. And those medication, most of them, they distribute all through your body. For every medication, what matters is what is in your bloodstream. But we understand that medication doesn't stay in your bloodstream. It goes to all your other tissues as well, especially in fat tissue. Many of those medications are lipophile, meaning they like to be in the fat tissue, and longer surgery is you're accumulating a lots of more reserve of those medication. And after the surgery, your body has to get rid of it. And the proportion that your body has to get rid of it are tremendously different in a 1 hour versus 4 hour surgery. Another thing, cognitive. Somebody mentioned cognitive changes or recovery after the surgery. Great point. There are studies that show, especially in elderly, this higher surgery, not only they have higher time to recover from, cognitively recover from surgery, but there is a permanent damage. Psychologically, they have done those tests. There's a damage, and that damage has to do with how many surgeries you get, but as well, more importantly, how long your surgery is. So, all of you who have been in the OR, you notice that the surgeons are very impatient about inefficiencies. Now,
I don't that.
I've never seen any sort of urgency come from you, Dr. Abbasi.
No, surgeons are so patient all the
Mhm.
time.
but I hope now you understand that over eons, we have learned that 2 minutes that doesn't matter to somebody who doesn't know anything, that has an impact on our actual outcome. That so every time that I myself, I think I'm much older and much more wise now, but I hope everybody understands. Every time that it takes 2 minutes to go outside of the room and get something and bring it in, my blood pressure already is much higher, and so because we know naturally those inefficiencies, not on the economic side, but on the patient outcome, that actually they do matter. They do matter, and they do matter a lot. But in the last 20 years, we have now studies that they show why they matter, how they matter. Like one of we talked about every half an hour adds 17% to the combined risk of the surgery. We did a study actually that shows that with the surgery that we do, when higher BMI, patients need longer surgeries, which makes sense. You have to work through more tissue and so on. But we could as well show the outcome are significantly different. Now, we did that study with 3 different surgeries, and all of our surgeries showed that higher BMI doesn't impact as much. And that paper is published, and everybody who's interested, just Google Abbasi, ABBSI, my name, NIH, National Institute of Health, OLLIF, and obesity. Then you can read that paper. That paper is available to everybody. But what we didn't show in that paper, and we didn't verbalize in that paper, is that this has a cumulative effect, especially on elderly, meaning that in elderly, time on the anesthesia add to the risk of the surgery is a linear kind of progression until you get to 3 hours. At 3 hours, and especially in elderly defined 75 years and older, that is exponential. And Bernice, we do a lot of elderly people in Hutchinson now, because we can do their surgeries under 3 hours, and that is a rule of thumb. On elderly 75 years and older, if you do surgery that are more than 3 hours, the risk doesn't grow linear, but exponential. So for that reason, if you talk to any anesthesiologist who does surgery in a surgery center, they refuse to do surgeries that are more than 3 hours. That is, as a matter of fact, one of the requirements in most of the surgery centers I have been involved. The total anesthesia times need to be less than 3 hours. Exactly what you guys described. Now I gave you some background, some base. Let's first answer some question there before we go to experts. How to be efficient, what to do, what to consider, and I'm trying to be very practical. Bernice, what did you do that what actual steps did you take that include you coming visiting us, but I'm sure it's more than that. So first of all, any questions regarding the base information data that I just provided?
So I think I'll let everyone else give their input here. Our team is always trying to prepare. I think that was one of the key components of being successful with Inspiring Coming to Kansas is we prepared from the minute we heard that we would be working together. We sent a team up there to make sure that we had the information to bring back to everyone. And that hasn't stopped ever since we started Inspired Spine here in Kansas. So we prepare every week that we know that we're going to be doing spine cases. We prepare instrumentation. We make sure that we have all of the supplies, that we have the things in the room so that we're not having to run in and out of the room, that we can maximize our time while we're in the operating room. And I think everyone here in this room just takes a part of it. And the biggest thing is teamwork. We all work together to make sure that we're covering each other, that everyone's looking for the next thing that we're going to need. So if somebody is in charge of instruments, that we're working with the next person that's in charge of supplies, that we're working with the next person that's going to be helping clean the rooms when we're going to be turning over, and so on. And not just in the OR, but really as a whole team at Summit Surgical, working from getting the patients ready in their pre-op, making sure that we assess the patient, that we know what we're going to be doing and what type of patient we're going to be dealing with, having the paperwork to make sure that pre-op can get them ready for surgery so that we can make OR time on time, and we are cutting on time.
And we also communicate. We let, like if we're getting ready to start or turn over, we make sure we let everybody that is involved know that we're going to be done in 10 minutes, or we're going to get ready for the next case, or what we're doing next. And I think that's a big thing too, is just communicating with each other and making sure everyone's on the same page.
One of the things I was really excited about that in many places when they hear I'm going to go and do surgery day, they say, send us your preference card. That's not the only thing you did. You actually drove or flew into Crookston and you observed. So how was that decision was made that instead of just getting the preference card to come actually a place that's done? So how did you guys make that decision? Number one, whose idea was it? Great idea. But as well, when you went over, what information were you hoping to achieve, to gather, and did you gather? I specifically, what was the result of that visit?
So the decision came from our administrators, knowing that our team is always looking to be prepared. And I think having a preference card just gives you one dimension of what you're getting into. The best way is to go out there and actually experience it. So Jamie's in the room. Her and I went up to Crookston to see and take notes, not just the stuff that you use or whatever supplies you need, but what people are doing, how people are doing it, making sure that we're taking notes of the little things that are important and how the team really works together, what the expectations are for everyone in the room, x-ray, scrub techs, nurses, anesthesia, and what everyone is doing to be more efficient, and then bringing that information back to Hutch and getting everyone that is getting involved in Inspired Spine here in Kansas to be on the same page and have the same expectations, so that we're all have the same information and be able to know that if I ask Brooklyn or Tracy, they both know what we're getting into.
Now, for somebody who want to get into this, say, number one, it's a good idea. If you're getting into a new kind of procedure, go and watch them doing it. But what advice would you give them? What should they look for? I mean, when you went there, I know this is come natural to you guys, but for many people, this is not doesn't come natural. Let's say there's a new procedure that you guys haven't done, and you go and now watch it. I would love to know what was the content of that, this little notes that you took. What was that? I mean, what are the things that you were expecting to get? What information, what specific information did you get? And what were you surprised? If it was something there that you said, oh, I didn't know that, and did you, can you go a little more about the actual details of the information that somebody should look for?
I don't know, the steps and processes of what the surgery was, because a lot of us here had never done spine before ever. And so we needed to know the details of what was the instrumentation. We took pictures, we took notes, we took pictures of how the rooms were set up, how you positioned the patient, how you prepped the patient. It was just detailed notes on like what you did in the procedure and how many people, what the processes were. It's just every little detail of the step we wanted to know because we wanted to be prepared for it.
Yeah. Now let's move to the next step. Okay, I came back and obviously we went through the instrumentation. I went with some people over the instrumentation, but as well the device people went over the instrumentation. If you actually, compare what we do to a regular spine surgery, I'm not sure. Bernice, have you guys done any regular spine surgery in Hutchinson yet?
We have only done kyphos, and that's been a long time before, so we were not really prepared for spine. I think one of those key things that I wanted to mention that we did gather from going up there was confidence. I think knowing that, we're going to go watch a procedure that we've not seen before. Not only is it just spine, but it's not a procedure that everyone is doing. So it's not like you're just going to watch a laminectomy and you've seen another 100 of them. It's a whole nother procedure. I think that is the biggest thing we gained from going up to Crookston and observing was confidence in you, confidence in the procedure, and being able to get that translated back to Hutchinson and say, hey, this is a good surgery. We can do this. It's something that's doable, and it's not as scary as we all thought it would be.
And and I think that is as well that the working as a team, and the team can give each other confidence as well. Like, Amanda, what's going on? Amanda is having a good time.
I'm so sorry, you guys. I'm really trying to keep it together.
Why? Amanda, half of the time, Amanda makes fun of me. Amanda and Alyssa, half of they have their internal, they have their inside joke, and half of the time those jokes are about me. They think I'm like a.
No, I would say more than half.
More than
like
half.
90.
But is it a joke if you don't actually understand it?
They always go over my head, but and the team can give each other confidence as well. Many times what happens is that when one person becomes less confident in the surgery, that is like a small little problem that it's contagious. That when one problem appears, and then that propagates to other people, and then and most of the catastrophes start with something small, but then if you're not prepared for that, then that causes another problem, that causes another problem, that causes another problem, and that is the mastery of the war, is that you have so many backups that one single problem or one weak team member doesn't make the whole system collapse. And I think it all comes to the leadership in the war, starting with the surgeon. But the long time ago, the surgeon was like a god. Even if he did a wrong thing, nobody was allowed to say anything. Thank God we have gotten away from that. And if you see something, say something. That is the formula here. But as well, I have seen that backfiring. I have seen as well lots of people who say things without really knowing things. You have to have a balance there, like, not just shouldn't be the confidence shouldn't come from lack of information. The confidence, the worst thing in the world is being very confident and having very little knowledge. That's where true catastrophe happens. But 90% of the time, I think in the war, we are in an environment that if you see something, you say something, you put a timeout, you solve a problem, and make no mistake, war is not repairing a car. Every person is different, and as a matter of fact, I'm always surprised that every time everything goes well and so on. So because it is like a battle, it's like a battlefield that the team really depend on each other to make it work. Now,
Dr. Abbasi, would you say that, like, because the OR and optimizing efficiency for it, traditionally, in the last century or whatnot, when we think of efficiency, we think of manufactured production, that sort of stuff. And it feels like with the OR, there's such a human component to it. You have all these people working together and doing all this stuff. Is that probably one of the biggest challenges to it? We can't just say, all right, we're going to get this machine that does this 100,000 times over and over again, and that's going to make us faster. It's how do we all work together in a way that we know our roles?
That is a good question for Bernice. I mean, how do you put a team together that they get along? Or even if they don't get along, they pretend they get along.
Well, actually, I do think that we have a great team. We were just discussing this earlier about how do we get people to get along. I think we all share the common goal, and the common goal is to get the cases done and get out of here. So everyone
That's a
laughs,
good
but
goal.
it really is to get everyone home. Everyone wants to, get to their loved ones. So the common goal is your time is not more important than everyone. Everyone is here. We're all here until the cases are done. The faster we can get the cases done, the better off we are. And I think that really does keep everyone together. So making sure that we're getting out of here on time. So
I think that's a great point too. If I say something from our OR experience, and I think Kim can attest to this, is we do a lot of cross training with our group so that we know that everybody kind of knows what everybody does. It also gives a sense of appreciation so that everybody realizes exactly what everybody's role is. And that allows that well-oiled machine to actually take place when you have that trust, when everyone there has the ability to do what they need. I think that's, for us, is what I've noticed. Our days are very smooth when everybody is on top of what they need to do. Yeah.
And if I may add an analogy to that, imagine, I'm telling Alyssa, go get me a Phillips screwdriver, and then you go and get me a Phillips screwdriver. Now imagine person X that's not here, I'm telling, go to the door, open the door, go stairs up, close the door, then use the key, go to that shop, go to the desk on the right side, then use the key from that place, open that thing, take that screwdriver, take that thing that has a shaft and a metal piece, and the metal piece, the end look like a cross, and so on and so on. You get where I'm going, right?
Oh yeah.
So you see, you have to have a good understanding of what you are going to do to be efficient. It's about efficiency. Now I'm going to give you an example. There are some X-ray tech. I tell them, give me an inlet view, and that's all I say. And then there are things I say: open that joint, move that joint, and now go up, go down, and okay, now we have our inlet view. Now I'm going to go one step further. I don't even have to say, give me an inlet view. The person is following the procedure enough that knows the next step is the inlet view, and I get my inlet view. And that is how you make a 5-hour surgery a 45-minute procedure. Now, and the mastery of that is make not only that you're financially more successful, that you're providing better care for the patient, because we discussed what the consequence of inefficiency on the patient outcome is, but as well, you make an impossible surgery a possible surgery. That means if you have that level of efficiency, when 5 surgeons tell to the patient, you will die of that surgery, there's no way you can have that surgery. They fly from Texas, from California, from other places to you, because you are the only person who can do that surgery for them. But that takes truly a team effort. And I hope that, did Tiffany, when you came to Crookston, did Tiffany assist me in that surgery? Bernice, do you remember?
Yes, I believe so.
Yeah. How much did we talk during the surgery?
We don't.
Yeah, well, that is the beauty of it. In a surgery, that and what you notice is that things are happening without we even talk about it. Mm-hmm. Now, certainly, sometimes you have to talk about it when you move the procedure, and if it's a new person and so on. But generally, you never get to that level of efficiency if people don't know what the next step is. That as well part of the the team building. But in many of the surgeries, I don't really ask for give me this, give me that, and so on. What I have learned though is that often, especially I'm sure you have noticed that often that we have a staff that they haven't done this procedure with me. I set up the table, I say what I want, but then I take it myself. And that builds the training that's needed to build that. Now, I can tell from my side what I can do to be efficient on my part. But that is not really what this meeting is about. This meeting is about if we can, the actual steps that Bernice, you have taken to enable us, like when we were last time there, Dr. Fleeman was asking if we should go from one room to another room, and we decided not to do that. Tell me about it. Now, what is the advantage of swinging room versus not swinging a room?
I think we decided that, we can turn over the room faster than we can move it to another room and start over.
We have limited equipment too, so 2 C-arms, moving them from one room to another, it's just easier to have more staff and everybody be ready to clean the room.
For people who don't understand what we do, we know it and it's natural for us. But once the surgeon put the last stitch in, and at that point, he's done with surgery. What are all the things need to happen? And there are tremendous amount of things need to happen. What are all the things need to happen until he can go and start making the first incision on the next case? Can you just run us through that? All the things that on your side need to happen?
So we start getting ready for all of this before the surgeon puts the last stitch on the patient. We have people like Lori outside the room that are ready with the cleaning supplies that we need. We have our extra nurse or scrub tech that are not in a case ready to have the bed made, and the slide board already on there. We have people that are already gather the instruments for the next case ready to be brought into the case, into the room as soon as the patient leaves the room, and we can start cleaning. Anything else you guys can think of that we do?
A lot of times we have, like, in the morning we assess what cases we have, and so we'll get everything that we can get ready for the day. So if we need a tourniquet for the 3rd case, we'll already have it cut and ready in the cabinet for a different case, and things like that, little things like that.
We also right away start going to pre-op and have a nurse there already assessing the next patient, making sure that that patient's ready. So as soon as the room is cleaned and ready to go, we can bring that patient immediately in, so there's no delay on that time period.
But yeah, fantastic. But actual steps, you know, there are lots of dirty instrument already in the room from the last case, right? So surgeon is done. You're telling me, fantastic. I didn't know that somebody outside is already waiting with the cleaning supply, waiting for the room to be empty to come in already. Is that what I hear?
Yes.
Fantastic. And then no, I hear that there's a different nurse that already has put the supplies for the next case, while the nurse who helped with the current case is getting rid of the dirty instrument and put them in a rack, I'm assuming, to take it out of the room, correct?
Correct. Yeah.
So what things in the room stay, what things are replaced? And obviously the cleaning is not the regular cleaning. For again, people, it's natural for us, but it's not just cleaning the floor or so on. When you say cleaning, what does it entail?
So that is wiping everything that is in the room, from the anesthesia machine, lights, C-arms, door handles, floor. Anything that's been in the room with the patient in the room is going to have to get wiped down. I think part of being efficient is discussing like who's doing what before, so that we're not missing the steps, we're not missing equipment not being wiped down. Everyone knows what they're going to be going into the room when we're turning over what you can do. Like if you need another nurse to get the medications, then they have the ready. If you're a scrub tech, then you're getting the instrumentation out. Everyone knows their role when it comes to turnover.
What I have noticed that, you know, that in some hospitals that were more efficient than the hospitals that are less efficient is exactly what you described, that there is a good plan about once the case ends and the patient, and obviously this all happens once patient is out of the room, correct?
Correct.
And at that point, everybody knows exactly what they are going to do. And as well, what I as well notice is that the waking up the patient is a huge factor in efficiency. And too bad Dr. Fleeman is not with us today. Now, do we always wake up our patient in the room, or do we sometimes wake them up outside of the room?
We try to extubate in the room, so we will be doing that right at the end of the procedure. I think one of the factors that does help is you telling anesthesia, we will be done in 5 minutes, and they can start working on that process of waking that patient up and being ready to extubate as soon as you're putting on the dressing or whoever's putting on the dressing, and we can move over to our bed and be ready to extubate.
Yeah. Now, Alyssa, you have been in few of my surgeries. We make those announcements, right?
Every time.
Yeah. We say we are half an hour away, we are 15 minutes away.
5 minutes. Away. Absolutely.
Now, there is a nice story about that. And when I was in the university for, I think, the third time, University of Minnesota, we were doing a 2-level fusion. We are literally 35 minutes or so, a little more, 37 minutes into the surgery. And I make an announcement that we are going to start closing in 15 minutes. And you guys all know that the sterile field, right? That the wall between us and anesthesia.
Ooh, anesthesia popped up so fast over that. Yeah. What? 15 minutes?
Anesthesia.
Reversal agents.
Yeah. Now, all of a sudden, their head comes above that veil, and she looks me in the eyes and say, "You're kidding me, right?" I said, "No, we are closing in 15 minutes." No, I missed to tell them that we are half an hour away, I made the 15-minute announcement. So, but again, certainly that was a little awkward in the room because one scrub tech was telling to the other scrub tech, don't scrub in. You're almost done here. Because that was before the nurse could go for breakfast and so on. So this is a good problem to have, okay? But still, if the anesthesia is not ready to wake the patient up, doesn't matter that I finished the surgery in 15 minutes. They stood there for half an hour to wake up the patient after. So part of this is on the surgeon to communicate about the progression of the surgery itself. So now the room is clean, the supplies are in the room. Now the patient is ready to come in the room. The surgeon has signed off, literally put initial of the patient. And now part of that goes parallel, right? While you are still setting up the room, the anesthesia bring the patient in, and enlighten us, Bernice, and the team. What part of that process can you do in parallel? And what part of that has to go sequentially?
Well, funny you mentioned, I have a couple scrub techs in here that would not love me because we will say, the patient is signed, now we're heading back. Ready or not, here we go. So we will, and everyone is making sure that we're not bumping anybody with the door as we're opening things. But if we are setting up, they have, a good 10, 15 minutes from just getting into the room to set up the room. So some scrub techs, don't feel comfortable setting up as the patient is rolling into the room. We don't have a choice here. We are going to do it that way. We're going to bring the patient in, and ready or not, here we go. I think we've learned that you are pretty self-sufficient. So we put what you need up in the Mayo, and they'll finish setting up as the case is going on. And if we're putting the patient to sleep, we still have to put neural monitoring on. We still have to do a Foley catheter. That all time we can do it, like you said, in a parallel manner as we're setting up the instrumentation or whatever else that we need to do to get that patient in the room. As soon as we get in there, then we start working together to get all of those things done.
And Bernice, I think that is your magic wand. You set the expectation and you help the people to achieve those goals, because that is, I'm going to tell you a nice story. And I tell my stories only to people I like. So hear me out.
I'm glad we didn't hear them.
So the story is about hot dog eating contest in New York. And my people might have heard it many times. And until about 15, 20 years ago, the record was 28, 29, 30. And everybody thought it is impossible to go above 35 or so. And then it comes this very young, very skinny Japanese guy who was doing vacation in America, saw that, went to Japan, came back next summer, and he needed money, just needed money.
Mm-hmm.
One set, he went from 30 to 60, where everybody, all these big boys, truck drivers, they come and eat in 11 minutes. By the way, I'm not encouraging anybody try to eat that many hot dogs at once, but all these big truck drivers, they eat 30. This skinny guy come and move the record from 30 to 60. His name is Kobayashi, and what he did in the game theory is called that Kobayashi effect. If you're interested, go read about it, because the Kobayashi effect is the concept that people have worked on and have won big prizes, including Nobel Prizes on the economic, is about how you set the expectation it's going to determine how your business is run. The Kobayashi effect is described as, and I'm going to tell you in Kobayashi word, he didn't look at how many hot dogs he can eat in 11 minutes. He took the process apart read the rules and took the process in small pieces, and he figured out how he can improve every little piece back by itself and then put the system back together. It's almost disgusting, but the rule didn't say you have to eat the whole hot dog at once, so eat at a hot dog, like a hot dog and so on. What he did, he trained himself to swallow the hot dog whole, not chew it or anything. Then he took the bun, put it in water, wring it out, and then eat them separately. No, I see that Amanda's face, but you see that there, for people who never took it apart and put it back together, 35 was humanly possible way to do that. In 1 year, he moved it to 60 by taking it apart, reading the rules, and putting it together. If the goal is winning the prize, he win it. He won it really, really nicely.
Mm-hmm.
And the Kobayashi effect is practically what you just described. I'm not going to accept 30 hot dog anymore. The goal is 60 hot dog. Ready or not, here we come. But then you would be surprised. You would be
whole new meaning to that phrase.
and you would be surprised how people can really, raise up to the challenge when you give them that. Now, if you all of a sudden say 15 hot dog is all you can do, 30 is for those big truckers in thing, then 15 is your benchmark. If you all of a sudden say 60 is our benchmark, then you set the tone there. And that is, I think, the most important piece of why in such a short period of time we could do that, and I have been there, I have been observing, even though it doesn't look like that, I do observe what's going around me besides what I do, and you push them in that direction in a very gentle way to say, this is the set, this is the session.
I think everyone's laughing. I don't know if it's that gentle, but that's definitely the key is to, I would say I just encourage people in a very assertive.
Now, but I think that the most important formula or the sauce to efficiency is that taking the process apart, optimizing each process by itself, and don't accept artificial self-made boundaries. Like, for some places, it is just impossible to do a turnover in 15 minutes. That just is a matter of impossibility. If it's impossible, then people won't be able to do that.
I think that is something that is not new to Summit. I think that is something that's been like this for a long time with all of our surgeons here, is efficiency, is getting everyone to learn what it is that you can to improve in your area. So instrument processing and, turnover rooms and things like that is, like you said, taking it apart and looking into each area and how everyone can bring their little piece to make it more efficient.
Yeah. What question I had for you when we did those cases, and we are going to do 6 or so of those cases next Monday, was it always the same anesthesiologist, or did the anesthesiologist can, because they have other duties, they have to still pay attention to the last patient wakes up. Was it the same anesthesiologist, or was it a different anesthesiologist for those cases? I think for 4 of them was the same anesthesiologist, but refresh my memory.
Yeah, so there's usually 1 or 2 anesthesia providers which alternate. Sometimes they go back-to-back cases. Some of them they'll do like 3 and then the other person will come in.
But I believe in the first 4 cases or first 3 cases, it was 1 anesthesiologist, and then it was I think for the 2 of them was another anesthesiologist. So that requires as well a good team on the PACU side, and I think that is a crucial thing that our team, are working on that. We have come a very good. We've become very, very efficient in very short period of time as well. Is that you need to have a team on the PACU that the nurse anesthetist or anesthesiologist trust they can take over of the care at that point. So they can go and spend time with the next patient. Can you talk a little about, how that sign out that they look like in Summit when anesthesiologists take the patient, bring them to the room, put them to sleep, wake them up, take them to the PACU. At what point the care is passed to the nurses what are the criteria, better to ask, that now anesthesiologists can transfer the care and take care of the next patient?
I think that is something that we're working with Brian Fleeman on some of that. Our PACU nurses are learning. That is definitely an area we're working on to get more comfortable with the medications that they're giving. And like you said, just knowing that the anesthesia provider is going to be able to trust the nurse that is taking the care of the patients. I think here there's been quite a bit of education going on with Brian Fleeman and the different drugs that they're giving and the pain management from your team, and obviously Brian Fleeman's ideas of different medications to use that really do impact how we take care of the patient. Some of them, getting away from opioids and being able to just take care of them, waking up in a smoother manner than we had before. The first couple of months that we did spine, we definitely see a difference now to have a patient in PACU 30 to 45 minutes instead of 2 hours trying to manage their pain.
Now, one of the things I'm really admiring Brian for, and I don't ever give a compliment easy. People who know me know that he takes truly ownership of the perioperative anesthesia, which pain control is part of it. Anesthesia is pain control. That's why we put the patient to sleep. And that's not just putting the patient to sleep and waking up, but he told me, that he prides himself of taking ownership of perioperative pain control, which anesthesia is, that's what it is. And that means, and that he helped us a lot to develop and update our protocol. I'm hoping that you got our most recent protocol, Bernice, and distributed to the
Yes.
Excellent. Now, one of the things, obviously, in that in this the pain management is the pain management doesn't stop once patient wake up. As a matter of fact,
No.
anesthesia is the pain management part, but once patient wake up, in some places, they think the anesthesia job is done when patients wake up. And my admiration for Brian comes from he taking ownership of that process. Now, we are getting close. I would say we should wrap it up. But I want to go around and say, like, please go ahead.
I don't really.
You hear that? We are not able to hear you if you are trying to say anything. But
I wasn't able to hear you.
Okay, so I wanted to go around. If we have a genie bottle and we have 3 wishes in our professional work, let's go around. If you had 3 wishes, what would that be to make the situation more efficient and better for everybody? Why don't we start with the Hutchinson team? What are your 3 wishes? And that 3 wishes could be toward anybody, including, especially to our surgeon. What are your 3 wishes? Let's go around.
I think
just one thing is just keep on working on the pain control, just making it easier and stuff for patients and post-op and the hospital side would be a good goal.
I think just being able to get more equipment, another bed would definitely help. So we could have 2 rooms ready, and that would make it more efficient and faster.
Absolutely. So you have 1 more wish. The genie is still going to grant you 1 more wish. What's the 3rd wish?
I mean, if we get another surgeon, that would be great. We'd run 2 rooms and
I just got my wish of getting another PA, so it might take a little bit.
So, Kim and Taylor, what are your 3 wishes?
My first wish would be for some more staff to make us more efficient. Taylor, what would our number 2 wish be?
I definitely agree, staff. I think number 2, oh gosh, that is hard because I think staff is the biggest thing for us right now over there. We have a really, really good team of who we have right now. I think we're kicking butt. We are learning every time.
Taylor.
I think that every case we do, we improve and we get better and better. And when we can get more staff in, we are training. And so yeah, we're getting more instruments. So we're getting that because there's some cases I know that we've had coming up that we didn't have exactly what we needed. So we're getting that together. So I would say all the instruments that Ashley needs, and that is a wish that is coming along.
It is. That one's being fulfilled as we speak,
Yeah.
which will help our efficiency as well. And I wish that we just continue growing and, like you said, get more surgeons in too, so that we have 2 beautiful operating rooms. It would be nice to have them busy.
So on provider side, Dominic, Alyssa, and I myself, what 3 wish? You guys go first.
This is tough because I mean, from the ISSC side of things, I agree with Taylor and Kim on saying the core group that we have right now, I 100% believe that they would do any job that we have ever asked them. That's why I say when we double cross train everybody about in our surgery center at this point could have do about everybody's job, and we probably tried. So that's just an emphasis on how amazing that we've adapted that side of things. I guess for me, I am a huge patient experience type of person. And my wish is just that every patient is getting the same amount of care, regardless if they are the 7 a.m. surgery on Friday morning or the 3:30 surgery on Friday afternoon. Surgery days get long. Our workers get overworked, especially when you are it. But that's not fair to the patient. So my wish is just that we continue to keep that goal in mind. That for me is just, I mean, that's my number 1 thing. Patient care experience overall.
Nice.
I mean, Dominic got to be in the OR for the first time last week or so. So what are some things that you'd like to change or wish?
Well, my wishes are all entirely selfish. So, you know, it's going to be right there. First, I wish for enough wisdom to make sure that I do my job like to the utmost. You know, I want to get as far as I can in my field.
Asking questions.
Exactly.
Not assuming that goes a long ways too.
Second one is kind of directly related to the first, is wishing for continued patience with everybody else that's around me. They're just like, everybody's so awesome to just kind of, you know, I'm a little baby deer, you know, and everybody treats me like that.
Little baby deer in the headlights.
Yeah. And then the third and I guess final one is more on like my fiance side of things. I want her to just continue to have a really comfortable time over there. So that way, if ever I do feel like I need support on the home front, she's always willing to tag in. She's ready to cook whenever, but it's my hobby. So I kind of do it anyways. But so that's
life balance is important. Yeah.
My wish is very practical. My wish is
Soccer.
that everybody walks around with a piece of paper, something that fits in their pocket with a pen, and we can do any mistake once, but then we write it down. Yeah, here you saw that. That is what I'm talking about. That experience.
Oh, wait.
But we write things down, and we don't make the same mistake twice. Now, in medicine, we will do mistakes. Things are not going to be. Some mistakes are trivial, but some mistakes are catastrophic. But we cannot afford to let any mistake go to waste. Now, and on the practical side, what I have learned, people who independent of what you do, what the people who develop are people who learn from the mistake and they incorporate that process to avoid that. Whereas they just, and most of those people I have seen that have that thing. And I used to have a bunch of cards in my pocket, and now people have cell phone or whatever works for you, that you don't rely on your memory to remember, and you make every situation to a learning experience. So again, come back to that my wish would be that everything you do at the end of that process, you know more. And if something didn't go well, you document that and then work on how you can overcome that. And that start with a simple thing like a piece of paper and a pen in your pocket. So
that definitely is part of our team here. I think everyone can look around the room and we know like Karen, Jamie, Tracy, they're always walking around with notes. That was part of our prepping for this week coming up is where are the notes? Who has the notes? We all took some notes. Everyone contributed to the notes that we took last time. So we learned something new and we're ready this time.
Awesome, Kansas.
yeah,
That warms my heart over here. I don't have a lot to say what happens when he's down there. So at least, I mean, that makes me very, very happy. I appreciate that a lot, you guys.
now the closing note is that this process, about 12 years ago, I started a form. It's called post-operative debrief form. About 5 years ago, that what's that thing called? That the national thing that set standards for the war and so on. Oh my God, what's called? They come and sometimes audit you. I just forgot the name. Bernice, help me out there. They set up the national standards, not OSHA.
Is it the Joint Commission?
Joint Commission.
Oh.
Joint Commission recommended certain steps, including the post-operative debrief, and so on. And in major places like Mayo, University of Minnesota, and so on, they have made it a routine. Now, I can be proud of that 12 years ago, 6 years before Joint Commission, I start practicing that in most of the places. Now, we haven't done that in Summit because I didn't deem it necessary to do that. But maybe we send you a copy of that form that I created 12 years ago. Okay, so
Please do.
and the thing about that form is that I used to do that only if negative things need to be said, and even though rare, and that was always what he filled out the form, he gave us the form. Then we started doing, and that is why Joint Commission recommends we do it for every single case. Then people don't feel singled out, then it is done. And then once we start using that form, that is how Crookston become Crookston. That is how we can do 6 cases a day. It took us many, many years, and many of those forms that filled out and so on, and they still put it on every chart, that form, they still put it on every chart. And I'm happy to say for last few years, I haven't filled out that form at all. It's just not necessary. Okay, well, thank you very much. I really appreciate all the good work you guys putting together. And I think that I'm hoping that the people who listen to this podcast, they take out of it what we are trying to convey here.
Mhm.
It's most of it is teamwork,
Teamwork and communication.
communication, and setting expectation.
Thank you guys for
Yep,
watching.
Please.
Thank you.
Thank you, everybody. Okay.
Thanks.
This was
Bye.
Medicine. Have a safe weekend. Bye, guys.
Bye.